I'm so grateful to be here. Ilya, congratulations, and all of the people who helped to organize. It's one of the best conferences, I think, and a lot of colleagues globally think the same. I'm from the Sheba Longevity Center, so just around the corner, yet it took me an hour and a half to get here. But as many of you might know, Sheba Tel HaShomer Hospital initiated the first longevity department for healthy aging people, not at geriatric age, in the world. And still, we are the only ones that do that, but more colleagues are joining. So we are in good collaboration with some other centers that I will show you soon. And we've been preparing this for 3 years and we've been talking about it. Then we started, our opening day was supposed to be October 8, 2023. So as you might imagine, we were delayed, but only by 2 months. And we started to see patients. We started to enroll them. And now I'm really happy to present some of our results, and not only about, how we structured and built the department, but actually what we see now 2 years after the opening. But before I jump to that, for those who might not know, there is also a Healthy Longevity Medicine Society, a society that was created in 2022, in order really to also have a place for medical doctors and associates and researchers, and really also for the public to find a place for the standards of clinical care, for the standards of how a clinic should look like, for the standards that will approve safety and finally bring us to the point that healthy longevity medicine will be a discipline or sub-discipline. When you go to the website, you will see that we have a structure, we have a council, we have working groups. They are very strategic. And they focus right now, for example, on how to build such a longevity department in a public hospital. They focus on hormone replacement therapies for women in peri and post-menopause. We also have a group of young HLMS leaders. So you have a student or whoever is interested, a youngster. That's a good place to be and to really get into the field. And we also work on data. So data registry is also a part of us. And then we also have a group working on education and educational standards. We really need regulation here in order to have longevity physicians really certified by medical boards as longevity physicians and not just by, reading something online. So that's what we are working on, and it's a very credible society. Just to pinpoint that it was actually very credible also in the development in some of the countries. Our neighbor, United Emirates, they implemented in the constitution of their country through the Ministry of Health set of the standards that our society developed in order to certify clinics. So you cannot just call yourself a longevity clinic if you did not fulfill the criteria of the Department of Health and did not get the approval. So finally, a real regulation that's really expanded to many countries right now as well. As I mentioned before, we are not working in a silo. We are trying to be as collaborative as possible. And when we were developing Sheba Longevity, we also worked with other centers, especially with Mayo Clinic Rochester, where they are planning to open a full longevity center soon. Right now, it's a little bit mixed with the health screening one. And of course, at the National University of Singapore, where this center is existing, but is primarily focusing on clinical trials. Nevertheless, collaboratively, we published a paper where we described already, how a patient journey should look like, how to make a proper longevity protocol, at least as the basis structure, in order to collect the right data at the right time with the right follow-up. So whoever is interested, you can just look it up. And really, encouraging you to have a look at the website. Now, turning into what we do and what's hopefully interested, going back a little bit to the reason why we do all of that. We all the time hear that we need to close the gap between the health span and the lifespan, and it's true, it's very important, but there is so much more to that, right? So healthy longevity is not only for healthy people, and health span versus lifespan vertical gap is not everything. We also need to know and be able to assess with objective biomarkers what's the threshold of a patient in terms of the health span. So the health span for a patient who was a cancer survivor might be different to a person who was an athlete all the life. A person with ApoE4 mutation will not get the same health span as a person with zero risk, and so on. So we are being asked very often by autoimmune patients, by cancer patients, by chronic disease patients, if what we do is at all also relevant for them. And of course it is. And the whole point is really just to know what is the achievable part and to measure it and then bring the patient to that level. And that's why it's important to work collaboratively, not only within the longevity group, but also with the normal sick care departments. And that's why Sheba is placed within a very, very traditional setting of a hospital, you know. So took a while to actually explain even to our colleagues in cardiology, oncology, neurology, what is longevity, and that it is not biohacking, and that this is not prevention, and so on. So it takes time, but I think it's worth it, because you will see that we do a lot of research projects now together, and we actually have people from those departments working full-time or part-time in our department. And not just any people, those are usually the heads of the department of endocrinology, neurology, sleep medicine, gynecology, and so on. So our vision was really to bring evidence base into the normal setting of a hospital, to build a department, and to focus on optimizing health span along the lifespan, which is actually the official definition of healthy longevity. And of course, as a clinic, as any department in an academic hospital, you don't do only the clinic, you also have to do research, and you have to innovate, meaning you need to collaborate with industry. And we had this mission, and we said the only right way to do it is to do it in a framework of a clinical trial. So we have initiated the so-called SHARP study. It's a large prospective longitudinal clinical trial on healthy individuals, 50 plus. It's called Sheba Health Research Population Study. And this is the protocol. The total number of the involved patients is or will be 1,500 patients. Right now we are at about 1,200. And it's a constant process because, as you can see here, they are coming back a few times. So they have a pre-screen, then they come to us, then they have a full assessment of 450 biomarkers of aging. Then they are being randomized into either a control group where they do not receive any feedback on their results besides of blood tests, which sadly they see in the system. And the other group gets interventions. So they have a summary meeting with a physician, explanation of all the results, and then personalized interventions for them. Then they come back, all of them, both of the groups come back at 6 months for another assessment of biomarkers, and at 12 months for the full assessment again, and then they being crossed over. So control goes to intervention, intervention to control. So we have a crossover comparison of those patients. What we are measuring, well, as I said, I cannot list it all here. It's about 450 biomarkers, but mapped in about 8 domains: stamina, cardiovascular, sleep, metabolic, systematic sensory health, andropause and menopause, brain health, which includes cognitive and mental health, and then life habits. And so it's a panel of functional imaging, of lab tests, of course, of special kits, and a lot of questionnaires and a lot of measurements also through our physiotherapists. And of course, as a clinical trial in longevity, we have to implement biological aging clocks, which are measures that are still valid and very important to be verified in clinical trials. Not exactly yet applicable in the clinic as, you know, as a protocol setting, but definitely I think it's our job to do it. We have at the moment 10 clocks. One is based on the blood. Then we have like blood tests, metabolic one. And then we have epigenetics, methylation, we have telomere lengths, we have cardiac echocardiography, biological age measurements, microbiome measurements from the gut and from the skin. And we have photo age based on photographies from the face. We have voice recording, and we have also the intrinsic capacity, physio age, and also a new clock from Professor Kennedy from Singapore, the clinical clock. And then we really personalize interventions. We focus on all of those areas and follow patients up. But I really want to say it's not only a clinical study. It's not yet another research place where only research is going. This was just a setting so we can get evidence, but at the same time, we're really creating a department that has a flow of a department. Right now, we have a team of over 75 people who are trained and working with us, from therapists and doctors, admins, and so on. We have a network with other departments and globally that we work together. And truly the biggest challenge was to find a way to have interns, residents, fellows, and specialists integrated in our department. So what they do with us will be also recognized for them as their work as physician or as their part of the training. So going back to the patients, when they come back after their assessment, they get a summary meeting with a physician for an hour, going through all of those markers, because one of the main parts for us is educating the patient also to achieve compliance. Compliance was one of our endpoints. So that's why we go one by one. We explain what is grip strength, why it matters, what is the study protocol for that, what is DEXA, what is body composition, what is it not, and so on. And then they get an app so that they can track themselves, and they get all of the results on the app and also the interventions. And so we continuously monitor them and like a big brother look, through the interface, what they do and what they don't do. And if they don't do, we poke them, we make sure that they actually do. So here are some of the results. Of course, it's not everything, but just, to give you a snapshot of a halftime. So this is actually from like 2 months ago. We had at that point of time 820 patients enrolled officially in the study. Before that, we had a pilot of about 300 people. And as you can see, almost 600 were in the intervention group and 200 in the control group. That's on purpose. And then they came the follow-up and 12-month follow-up. So this is a result after 1 year for some of those patients. As you can see here, this slide is super packed, but the bottom line is intervention and control patients were almost identical in terms of their physiological markers. So the group was very, very similar, and the baseline is united, so exactly what we needed. And we had also a very, very good split up between men and women. So we had the same start for everybody. They were all healthy, they were all in good health, and the groups were balanced. Good health for us means any person who is not terminally ill or fully neurocognitively declined, meaning we have patients with chronic diseases that are stable. We have cancer survivors 2 years post-cancer treatment. We have autoimmune disease people, and so on. And one of the clocks that we use, the biological aging clock, the hematologic one, is actually giving us results pretty instantly, which we very much like. And we were able to follow them up 3 times at 0, 6, and 12 months. And we were able to divide the people into 2 groups, the ones that were biologically older and biologically younger. Those who were biologically younger, we did a correlation, of course, with some of the biomarkers. This list can go down to 450 all the way down, but the things that were actually statistically significant and we were able to see is the following. Those who had lower biological age, all of them definitely had in the DEXA lower visceral fat mass. Their waist circumference was low, in such a simple marker fully ignored in the clinic. The systolic blood pressure was the biggest marker for that. And also what we are testing in the sleep apnea at home with the sensors like mini somnography. And the apnea score of over 3%, whoever had less than the 3% apnea score was lower, meaning no sleep apnea, also had lower biological age. Also, people who were doing better in the brief best test, this is a very complex physiotherapy test, really to check the balance, the agility and flexibility of the patient. and strength, of course, the speed, 6 minutes walking test, and then oxygen saturation on normal base and sleep duration. And then less correlated markers, whereas lower body mass index and fat index, right? So very, very basic ones were the least correlated, but still valuable. So in the 6 months intervention, so in the group that was in the intervention and we did intervene with personalized recommendations, we definitely saw some results after already 6 months. Weight reduction, body fat decrease was pretty impressive. Vitamin D increase, of course, we supplemented wherever it was needed. LDL and HDL, LDL reduction, HDL increase was also visible quite significantly in both groups, but much more in the intervention group. What is it telling us? It's telling us, first of all, that the intervention group, first of all, we saw that the biological age went down. So almost already 6 months are enough for people to decelerate their biological age. The control group who did nothing, let's say, they aged at the same time. And what was very important for us was really that most of the people also improved massively in cognitive score. We have a brain training for those people that is systematic and adjusted and personalized, and we see an improvement there. Also, sleep quality and physical capacity improved in most of the people. However, another thing that is interesting, and I will just point it out, just to finish it up, we saw improvements in both groups, in intervention group and in control group, but much more in intervention group. Why do we see improvement here? Because, as I mentioned, the control group doesn't get any interventions and no feedback from the doctors, but they do see at least their blood data. So most of them actually went and saw it, and they had intrinsic motivation to change their lives only based on that. And that was pretty amazing. So that's what we see so far. Much more will be presented next year, hopefully. And thank you so much again for everything.
We still have some time for questions. Over there.
How do we enroll? How do you order the give response?
Yes. So yes, we have a waiting list of about 1,500 people. So maybe you registered a little late, I'm sorry.
Can you give us any?
If you would be over 80, you would get a green pass, because we also go by age groups. We have to have a balance. So we go from 50 to 65, 65 to 80, and 80 plus. And very, very quickly, the first two groups filled up. So, but we are open now from 2026 also for patients who are not in the study. So if somebody would just to come and to do the tests, they can now do that as well. You can come as a patient, yes. Okay. Just go to our website and for that you will get a response. For the study, most surely, unfortunately, not anymore. Sorry.
Evelyne, following here, up here. Okay. So following up on that sounds terrific. And I wish that my primary care doctor would treat me like that. And that's basically the vision I think that we all share for the way that medicine and this year and onwards should look like. But what's Sheba longevity vision for taking that forward? Because obviously, even if everyone here would get into the next cohort of the study, that's one hospital. What's your vision to how Sheba can make this larger impact and onwards in Israel and out of that?
Yeah, so actually, you are a primary care physician? No. Sorry, because you mentioned So two main things, how to make it bigger and how to make it scalable for Israel and the whole world. Our vision and mission was to set an example and to start interaction also through this with the primary care physicians, because some of the recommendations, are through the family physicians, and we also send the summaries to them. We are trying to engage them more. This is the chance. And trust me, a lot of them react very negatively, extremely negatively, to the point that aggressively. A lot of them very positively, but a lot of them not. Like, why would you do something at this point of time when the HbA1c is 5.7? Because it's prediabetes. Have you ever heard of it? It's to that point. And it's not Israel unique. It's all over the world, from what I know. And so changing the mindset of the primary care I would say 60% of what we do can be easily implemented in the primary practice. That would be one goal. The second goal is, of course, to convince healthcare insurance that they have an economical point here, because when you do just a simple calculation with ChatGPT on the improvements of the people even after 6 months, even if they have zero contact with the patient, with the physician, that already saves massive amount of costs going forward. So we are in discussions with some of the biggest insurance companies or the healthcare system in Israel. Maybe it will be the point to implement it also that. So, yeah.
Thank you for your talk. Sorry to bring a bit of a morbid subject into this, but I hope not very soon, but eventually patients will die. I wonder if you have looked very far ahead and developed a component of tissue donation and planning to build that component up, generate some data, and perhaps even release it for research.
Oh, that is a cool thing. So so we are looking at morbidity, and we will look at mortality at some point of time, sadly too. We actually have a retrospective study from the Secker patients. Hopefully the publication will be out soon on the mortality and how that helps. But didn't mention that we are collecting a biobank. So we have some of the things: vaginal swab, hair, microbiome, urine, and a lot of blood. Actually, a good point that maybe at some point of time people could give us a bit more. It was a struggle, first of all, to get an ethical commission approval to actually collect some of the samples. It's not easy in Israel at all, but we would be hopeful, at least for some muscle biopsies or a pitch of a skin, working on it. But yeah.
It would be nice to
up
add
here
sequencing of genome.
Genome we will have. So that's if somebody can sponsor. So we have the sample. We are trying to find a place that can run the screens for us. That will be there. We have to have it. It was just a struggle during the war, even to ship the samples, and our microbiome at Weizmann got hit. So we have not always been fortunate, but it's a great idea, by the way. Thank you for that. I think I will bring it into the team to discuss it, yeah.
Yeah, up here.
Yes.
Hi, thank you for the talk. So I like the areas where you're researching and you're discovering. I wonder, from the perspective of the end user, the customer, the person, like all these plan and these pillars, and there's so many things to swallow and so many things to take and so many practices to do and things to remember. I mean, one have to manage their own longevity as if, they manage a PhD project. I mean, this is a whole, it's a big undertaking. So I wonder, how do you actually monitor that this is implemented? And also in your talk title, there was the two magical letters A and I there. And I wonder, what do you do with AI?
Mm-hmm. Yeah, great question. So, it's very difficult to explain to patients everything. And they grasp quite a bit, But you need to train physicians to actually talk to the patient according to what's sitting in front of you. Not easy, but doable. And then the patients are going on a journey with an app where they have a constant contact with us. They also have follow-up with the nutrition and the physiotherapist on an ongoing basis, exercise and nutrition. We see quite a good compliance. Even, patients 80 plus, they have a higher compliance than the younger ones. So that's number one. Number two, AI. So that's very complex, but in a brief simplification, what we are building is, of course, scores for health trajectories, meaning out of the 450 biomarkers and the follow-up and all the clinical data and the questionnaires and the interview and so on, we are training LLMs, of course, right? So that we will have actually a health trajectory for each patient coming actually to the hospital. So rather than like all of the clocks going from sick persons, building the clocks, applying to healthy patients like we usually do, we will build health trajectories on the healthy patients and apply them actually to the whole hospital for the sick patients. So we are very lucky that we have an AI team actually working on that separately. On a small scale, we are, training a chat box for what you said. How do you make sure that the patient who has maybe 70 questions after the summary, which are repetitive and annoying for the doctor, can ask the chat box and stuff? Yeah.
Very nice program. I didn't see any immune biomarker or inflammatory biomarker in your follow-up. Is there any reason for that? Because this is really, well characterized, at least to some extent, for some of the parameters.
Yeah, no, we have. I just really could not show you everything. No, we have quite a panel in inflammation. Inflammaging is one of our biggest points. Actually, we have a paper coming out on the intersection of cancer survivors in inflammaging. Quite interesting. And no, we have CRP, high sensitive CRP. We have C9 and C10. We have quite a bit of them. ALP, AFP. And we hopefully will have, in a collaboration with Technion, also the inflammation panel of Professor Shanor. So, working on it. Yes, it's super important. Of course, we acknowledge that. Yeah.
Do you collect information on accelerated aging, like some of the medical treatments, suppose chemotherapy? You can check the before and after, and you can really get some kind of accelerated aging?
Yes, sure, absolutely. Yeah, no, definitely very important point. Yes, we do. I mean, we in this study only we are not able to accept patients who start an active treatment or who are on treatment for cancer unless it's only the follow-up. So it's 1 year after chemo only and more. And of course we have markers for that, but it's my personal interest. So we also have a study now with the oncology department where we will measure before and after and during, and based on this do the prognostic evaluation, which is not new, by the way. I did that in China, and we see very clearly that there is an acceleration during the treatment, but then the biological age comes down. The only thing is, can you accelerate the sloping down? Like, you get older and then you want to get younger again to your baseline. How fast you get there, this is the point where we have to intervene. But and we have detected quite a bit of cancers, sadly, also in our center. I think maybe, at least 12 patients were, through our measurements and screening, we diagnosed some pretty bad cancers, yeah.
Are they ruled out once they're diagnosed?
Sadly, yes. Based on the protocol of IRB, we have to eliminate them. Yeah.
Will you open the biobank to researchers out of Sheba?
Oh yeah, sure. I mean, the moment already now, some of the samples are in collaborations with external partners. They take it. And once we have all the biobank as a data form, then of course we are all for actually open publishing. Yeah.
Do you do some? Maybe you said, and I didn't understand, brain imaging at different stages?
I wish. So we had some collaboration with the Reichmann University for the brain MRI, but it stopped during the war, unfortunately. The only imaging we do is with EEG, and the EEG TMS for early prediction of mild cognitive impairment. Otherwise, we have only cognitive testing. We would love to do imaging, but it's very expensive for us.
Yeah, but you can do some brain CT and then look at the different atropias and so on, even with brain CT.
Yeah. Yeah, a little difficult financially because we have a very short budget only for the study. But yes, optimally we would love that. Yeah.
Okay. Thank you very much.
Thank you. Thank you.
One of the best talks.